fibromatosis, or the pallor, which may again indicate that he may be suffering from anemia, which may be again related to some neurological illness. So the examination of a patient must be done from a following this, that first of all we must do the higher mental function examination, then the cranial nerve examination, then neck and trunk examination, motor system, sensory system, reflexes, sphincteric and autonomic nervous system, then we must look into the stature and gait. Unless we are very systematic in examining all the various system of the body, that we are unlikely to make a diagnosis in a particular case. Now coming to one by one, that first of all is the higher mental function, which is also known as higher cortical functions. Here we like to see that patient is oriented in time and space, his capacity to sustain attention and mental efforts, then the speed of the response and ability to give relevant answer. Next side is the bedside assessment for the attention and memory, that we do a 3 or 4 digit forward or a backward numbers, that is the number which are given. Supposing we ask him to subtract 3 from 100 or 7 from 100, that is another method, that is the subtraction, and here we can find out whether he is suffering from any organic brain disease or not. Similarly, in the digit span, supposing I tell him that 689, and the patient should either first ask him to repeat 689, then we ask him to reverse 689, that he says 986, like this. So ultimately you can go for 3 digit span, 4 digit span and 5 digit span, and one can know whether he is ability to do that or not. Then the recall of the events and the various item, asking the patient to who is the Prime Minister, who is the President of the country, where do you stay, and like who is the local MP in your area, what are the various places or around. You can always find out he is correct or incorrect, or ask his telephone number or some relative number, and check it from the other corroboratory people who is with him. So one can always find out whether he has some deficit or not. An account of the previous illness, if the patient narrates the story himself, a good medical attention, that he provides you the dates, it provides an excellent amount of memory. A patient who will give you a absolutely correct history, that in November I was having this, then after 10 days I was suffering from that, I went to that doctor, I went to this, it means his attention is very good, his memory is good. Whether his coherence and his thinking process is that is correct, he has no abstract thinking in that case. Then note down whether patient is having aphasia or dysphagia, or the nature of any spontaneous speech, ability to read and write, execute written and spoken commands, and capacity to name the objects. Calculation, you give him some calculation, 3 plus 3 is equal to 6, 3 into 3, and if he is able to do it, then make some common drawings, make a triangle, make a quadrangle, make a circle, and ask him to draw the similar thing. And if the patient is having some parietal lobe lesion, you will find that he is not able to do it. Or if he is suffering from Parkinson's disease, he may not be able to draw the circle correctly, his hand will waver, and you can find whether he has tremors or not. Similarly, if all these functions are there, and we can go for a little further scale, that is the MMSE scale. This is the mini mental scale of examination which is done. There is a table. This normally takes about 3 to 4 minutes to do the memory requirement. So these patients who have a memory deficit, we should evaluate them from these angles. Then coming to the testing of the cranial nerves, all the 12 cranial nerves should be examined in detail. But here I can tell you, when you have a paucity of the time, and if the patient is suffering from some lower limb illness, It may not be relevant to do all 12 cranial nerves because you will be doing lot of this. If supposing the patient doesn't have any problem about the smell, so forget about the first cranial nerve. You can skip it over, or just ask him if you can smell the food or this that. But if the patient has any anterior cranial fossa lesion, definitely then the first nerve will be affected, and one must test by the various method, that is the 3-step method should be done. Then the test of the smell should be done. Then visual field should be done by a confrontation method, that you make the patient sit at about 1 meter, and the confrontation method is done, and one can find out whether there is any hemianopias, bilateral, monoocular, or whatever it is can be found. Then the optic nerve must be examined by the fundus examination. This is a part of the examination, that each physician or a specialist must know how to examine a fundus by a ophthalmoscope, and he must possess one and do the fundus examination, because it can give you the clue whether the patient is suffering from hypertension, papilledema, optic atrophy, or any other disease. Then is the ocular movement, that we do the both saccades and the pursuit movement in a case to find out any deficit, and usually it is the 3rd, 4th and 6th nerves which are conjointly done for the ocular movements. Then look for the pupil size, reaction to the light and its accommodation, because this can give you another clue whether the patient is suffering from 3rd nerve palsy or not. Then look for the 5th nerve by checking the sensation over the face by the cotton wool or the pins. Facial movement is observed when the patient smiles, speaks and laughs, so you can always find out when you are talking whether he has any facial nerve palsy. And then hearing loss is evaluated by the giving a words to him at a distance, and one can find out, or when one is speaking to him, whether he is tilting his head or this, one can always find out whether there is a hearing loss or not. And then important is the vocal cords examination should be done, because 9th, 10th and 11th nerves and 12th nerves should be tested together. Look for the palatal movement, look for the vocal cords, and ask the patient to protrude the tongue in the resting position, and one can find out whether there is any deficit, there is a fasciculation in the tongue, or the tongue deviates to one side. So this is important. And if the patient has any dysarthria or dysphagia, examine the jaw jerk, buccal and the sucking reflexes here are very important, because they can give the clue that the patient may be suffering from the bilateral pyramidal signs, which may be a stroke, that is the pseudobulbar palsy the patient may be suffering from if he has a bipyramidal lesion. Now coming to the examination of the motor functions, examine the speed and the strength of the muscle. Then look for the muscle bulk, expose the patient as far as possible, his legs, arms, and see whether there is any particular atrophy of the limb or any particular muscles which are atrophied. Look for the bulk, whether the bulk, by bulk I mean is it may be hypertrophy also, because there are certain diseases where there may be hypertrophy of the muscles, especially in the children, and that is the Duchenne and the Becker's, one can always find. Look for the coordination of the movement, that is done by the finger and toe method, or by touching the opposite knee with the heel and then bringing it down to the heel. Then they ask the patient to get up from the squatting position. This is very important. Many a time you may not find that the patient is suffering from any motor weakness, or he may not complain, but he still says, I have a difficulty in walking. And many a time when you ask the patient to squat and then get up and walk, you find that it is unfolded. Then weakness is graded by the MRC scale, that which is grade 0, which is a complete paralysis, and to grade 5 is a normal power. So they are 0, 1, 2, 3, 4 and 5, and accordingly the patient is put into the MRC scale, because this is very important, because when the patient is under observation, you can always find out whether he is improving or is deteriorating once you have noted down the MRC scale in these cases. Then the deep tendon jerks must be tested, and in the upper limb, bicep, supinator and the triceps; in the lower limb, knee and the ankle jerks. Then superficial reflexes, that is the abdominal reflexes, if they are absent, they may indicate a upper motor neuron type of lesion. The plantar reflex, which is also known as Babinski sign, which is done by the stroking of the sole of the foot, where the great toe hyperextend with the fanning of the finger, is a very important sign which may indicate that the patient is suffering from pyramidal tract lesions. Then the tendon jerks should be graded from 0, that is the absent, to grade 4, that is the clonus in these cases. If the patient is having a clonus, it means possibly there is a pyramidal lesion which may be supratentorial or any other place, or it may be a cord lesion in that case. Or if it is 0, it means the patient may be suffering from some form of myopathy or sometime neuropathy. Most important is the neuropathy. And in cerebellar disease, the reflexes are of pendular quality. Then the testing of the sensory function is very important, that it needs a full cooperation of the patient, not necessarily to check each dermatome, because it is very difficult. The dermatomes are overlapping each other, so one may not get a full picture, but it is very important that the patient must be very cooperative. Don't confuse the patient, make him at ease, and then do the examination. Do a quick examination of the face, neck, arms, trunk and legs with a pin and the cotton. You can find out whether there is any sensory loss. If the area of altered sensation is found, then look whether it is a diminished or a loss of sensation toward the normal area. Then any difference in the two sides is extremely important. There may be a lesion which is in the brain, and thalamic lesion which may do the alteration in the sensation in these cases. And then is a zone of hyperesthesia may be found, especially in the cord lesion. This is a very important. Then test the stance, gait and the coordination in the patient. The neurological examination is incomplete without watching the patient stand and walk. This is a very important. Make him stand, do the Romberg sign, ask him to close the feet and close the eyes, and one can always find out whether he has a ataxia or not. In cerebellar and the frontal lobe disorders, the abnormality in the gait may be the only sign in most of the cases. Otherwise, you may not find any clinical finding in this patient. And in Parkinson disease, stance, posture and lack of automatic adaptive movements are the only clue. Here the patient may walk with a just fascinant gait, and he is keeping his arms just by the side of the body and doing no movement, and he has a masked faces. So one can always find out he has features of Parkinson disease. Then coordination can be further tested by finger nose test, then dysdiadokinesis and the tandem walking. Then Romberg sign, which I have already mentioned, that is often regarded as a special test of coordination for the lower limbs. Then it is a test for the loss of position, sense of sensory ataxia in the legs, and not of the cerebellar functions. Then the same patient must be examined for any neck stiffness, Kernig sign, because he may be suffering from meningitis. So these are very two important positive tests for in meningitis. In neck stiffness, we try to flex the neck toward the chin should touch the front of the chest, and in the Kernig sign, raise the leg at the hip and then bend at knee and then extend the leg from the knee position. The patient will frown in pain, and that is a positive test. These tests are positive in meningitis, subarachnoid hemorrhage and meningism. Neurological examination is incomplete without doing a CSF examination. but then there is a set of procedure which is done, that it must be done in a cases where it is warranted, and it is a very important tool in the diagnosis of various neurological illness. Exclude papilledema, which is a sign of the increased ICT. When there is increased ICT, do neuroimaging in these cases to exclude any space occupying lesion. Send the CSF for cytology, biochemistry, culture, viral studies, and keep one sample in the fridge for any further requirement. And concurrent blood sugar should be done at the time of the CSF, which may be correlated. In conclusion, a stepwise approach, if it is done in a neurological patient, can not be overemphasized. The diagnosis is a mental act of integrating all the interpretations and arriving at a single diagnosis with a differential diagnosis. Thank you so much.
Dr. Dhameja, can you please tell us some of the common cases which a candidate can expect in the practical examination, especially of the CNS?
You see, the commonest case which one is likely to get in a CNS examination is paraplegias, hemiplegias, then Guillain-Barré syndrome, that is the patient may be having areflexia. Those are the cases which are common. Then stroke cases, or patient with some localizing sign. Then muscular diseases, like patient may have myopathy, which may be congenital, or Becker's type Duchenne myopathy. These are the common Gardner problem, which are always admitted in ward, and they will go for examination.
So CNS examination is one such case in which patient cooperation is of paramount importance.
Exactly.
You just can't do a CNS examination if the patient is uncooperative.
Definitely.
And so many times if the patient is of old age, he is unconscious, and if he is not very willing to cooperate with you, how should a candidate face him in the examination? I mean, how should a candidate deal with him?
You see, the neurological examination itself in a unconscious patient is a very, very important, and it is extremely important that you go from step to step again. If you are not able to do higher mental function in these tests, in these cases, look for first ocular movements in this case, whether the patient look for pupil size, whether there is a conjugate deviation of the eyes toward the side, one side or the other. Then ocular movement in all pursuits, it should be done. Then neck rigidity one should look. Then see for any weakness, localizing sign on either side. Then reflexes, which may be asymmetrical in these cases. And then finally the plantar is a very, very important sign which may be giving you a clue whether the patient is having this, or look for any twitching or any abnormal movement, rigidity. So one can always make a diagnosis. In fact, many a times the diagnosis in an unconscious patient may be much easier than doing in a person who is not cooperative with you.
Okay.
So this is very important aspect.
So do you expect a candidate to be able to read CT and MRI while
Yes.
appearing in a CNS examination?
If he is appearing for DNB or MD medicine, he must know CT, he must know MRI. At least basics is a very important aspect, because these days, if these is not done, one cannot pass the examination, I believe.
Okay, sir. Any practical tips which you would like to give to the candidates?
I will say one word here: read your clinical method again and again, practice it on the patient, because in the examinations you may not get into the steps like I have already enumerated, that is the higher mental function, then motor, sensory. If you leave one step, you cannot make a diagnosis in these cases. Always do, gait, stance, rigidity, and these are very important. Unless it is done, you are not likely to hit a diagnosis in these cases. And the history is of paramount importance. Spend time, probe the patient into it. A good history will give you a clue about the diagnosis.
So finally, can you please enumerate? I believe the session is till 4:30. Yeah. So can you please enumerate the things which a candidate should carry in the final examination for examination of the various nerves? Like he's supposed to carry a tuning fork, I believe.
No, there are actually 4 or 5 things which the candidate must have. One is the tape for measuring the size of the muscle, whether it is atrophy, hypertrophy, or this that. Sometimes the lengthening may be you have to measure the leg size, that the one leg may be smaller than the other, but they are going to give you clue, because in the just inspection of the patient may be having pes cavus, and then you find that the one limb may be shortened or one limb may be atrophied. Supposing the patient is suffering from polio, one muscles will be atrophied, one limb.
One of the limb will be atrophied.
So unless he knows how much is atrophy, it is a difficult task. Then second important is most of the examination hall will provide, you see, these bottles containing for the smell, that is the asphytida or peppermint or the olive clove oil, which can be used. But it is always better that you make 3 small bottles, penicillin vial bottle, which we used to do it, and carry these 3-4 things with us. Similarly, carry some in one bottle little salt, little sugar, because you can then test the sensation on the tongue, whether he has any loss of sensation in the tongue. Then he must have a cotton wool, he must have a pin with him or a roller, which is many times. He must have a good hammer which have a good flexibility, so that he can get this, and every student must have a stethoscope with him.
Right, sir.
Because neurological examination is also incomplete unless you check for the various bruises in the neck, in the other places, because that may be one of the signs which may be important in these cases. So a complete and a pencil marking pencil. So actually 5-6 things are very, very important a student must have in his bag when he is doing a neurological examination. If he doesn't have, he is going to skip it, so his examination will be incomplete. If a good examiner, old examiner is there, then he will be just caught.
Thank you, sir. I would just like to repeat the things which a candidate should carry always while appearing for a DNB final examination, especially if he is supposed to get a CNS case. He should carry a measuring tape. A measuring tape can be useful for examining, like the sir had just said, for examining a case of polio. He should carry a tuning forks.
Yes.
Tuning forks.
And one torch also for the eyes.
Yeah,
wonders.
He should carry a tuning fork, preferably of 256 hertz frequency,
yes.
I believe.
Yeah.
Then he should carry a torch, and torch should be of sufficient good size. I mean, it should be not a
illuminating torch. Yes.
He should carry a cotton pen, hammer, stethoscope, pencil mark.
And ophthalmoscope is mostly available in the wards. So if he wants, it can be usually given at the time of examination, because we do not expect most of the MD student to buy a ophthalmoscope. But if it is there, it is very important. In fact, in our time, ophthalmoscope was one of the necessity that we were carrying in the our kit.
Okay, sir. So one very basic question.
Yes.
So candidates have been asking, and it's my personal experience also. So sometimes it does happen in the examination that the candidate just fails to answer questions. He is just not able to answer any of the questions. So, sir, in the end, do you ask some questions which, if the candidate can answer, you would like to make him through? Some basic questions, sir. Some very basic questions about the CNS.
The very basic question is this: one must read Indian books. That is a very important thing, and one must know the various diseases which are prevalent, neurological diseases which are prevalent in the our context. Supposing I ask a patient candidate, tell me the various diagnosis, differential diagnosis of peripheral neuropathy. I give example. He may narrate so many things. He may say peripheral neuropathy can be seen in this, some drugs, this, that, but unless he mention leprosy, he is not going to pass.
Correct, sir.
You agree with me?
Correct, 101%, sir.
Hey, so this is a very important, that our students must read Indian books of all subject practically. Now I am not emphasizing neurology, but neurology detail must be known. Similarly, to give another example, the patient is having some blue spots. Why the blue spots have come? Is the patient is having drugs? Which drugs? Or he should look for some marks, which may be, a drug effect of something. So this is an important thing, that in the examination, if he has missed, then the examiner is likely to ask him, because he knows the case which has been put in the examination.
Very well said, sir. Well, friends, it is very important. While you are appearing an examination, you should know what is the Indian scenario in it.
Call from Ranjit.
Yeah, good afternoon, friend. Hello.
Hello, on karo. Hello, I am Dr. Anirudh from Bokaro, sir.
Yes, sir.
I have got a question. I have already asked this question before, but when the examiner comes after the history and the examination and he asks what is your case, then should we follow the entire protocol starting from chief complaint, history of present illness, past history, like that, or we will give a summary to him?
Okay.
And a provisional diagnosis.
Though it is very important that you start from the chief complaint, then go for the history. Unless the examiner says no, if he is in a hurry, he may straight away say you come to the provisional diagnosis. Most of the time the examiner has a time to go through or listen to the story which the student is going to mention. So be prepared in that order, and you will never go wrong, because if you have not done a good this chief complaint, everything, so one is likely to flutter in the provisional diagnosis and the differential diagnosis in this case. Always when you have a provisional diagnosis, keep in mind a differential diagnosis in your mind, because many a time the examiner may think that possibly this provisional diagnosis has been prompted to you by somebody in the examination. So be prepared with a provisional as well as the differential diagnosis in a particular case, and then make points that in this point is for, and this is point against this diagnosis. So then the examiner knows that he has done a good groundwork for this particular patient.
Right, my friend. You should never say this. You should never come to the diagnosis straightforward. You should always start with the history of present illness, chief complaint, past illness, and all that. You should never say this is a case of space occupying lesion, or this is a case of hypertension, or this is a case of cirrhosis of liver. You should present a complete history first, and then come with the provisional diagnosis and then differential diagnosis along with it. So, my friend, I think this was the end of the session today. As you all know, these sessions have been designed to help you in preparation for your final DNB practical examination. In practicals, you will have a long case, short case, ward rounds, and a viva. 50% of the marks will be for the clinical component, and 50% of the marks will be for the viva component. You are supposed to pass separately in each of these things, clinical and viva. Then one more thing, my friends, history taking and examination is an art. It cannot be mastered in a day. You will have to learn these tricks thoroughly, practice them on patient repeatedly, and only then you can be confident of presenting your case to the examiner in the final examination. For the purpose of same, it has been repeatedly emphasized, and I would like to repeat again that please do form DNB clubs in your department. You can have a DNB club with your fellow friends or with your seniors or maybe your juniors also. You can prepare cases, present to them, ask for their feedback, improve upon them. You should do this thing at least one case presentation per day. Only then you will know your practical weaknesses. See, it's very difficult to finally present your case on the final performing day. You should know what are your weaknesses and what are your strengths. Only then you can build upon them. So please do form DNB clubs. Have discussion with the consultants. you have got DNB coordinators in your hospital. They will be glad to help you in each and every possible way. If you have any sort of query, please don't be hesitant to ask them. You can also mail us your query. You already know our website and you already know our email address, that is nbefellow@yahoo.com. Okay. One more thing, in some of the specialities, objective structured practical examination have been introduced by converting part of short cases and viva component, and these have been introduced in ENT, ophthalmology and pediatrics, and we are likely to introduce this OSCE in other specialties also. Examiners, my friends, expect only just basic clinical competence and basic steps in clinical history from you. Just a basic examination, investigation, differential diagnosis and management can get you through, believe me. And you will have limited time in your examination for preparation of cases, and unless you are well prepared, you may not be able to deliver it finally. You should practice the skills of case presentation by covering key points in history, clinical examination, investigation, differential diagnosis and all that. One more thing, for the benefit of our candidates, we have put a list of the sample cases for clinical examination which you are likely to get in the final examination. The list of these cases is available on the website,